Good afternoon. So I'm going to strictly stick to the 20 minutes that I've been given. First of all, I'm going to acknowledge people in my lab and my collaborators, particularly Cheryl Gregory Evans, who happens to be my wife, and Zia Wang, who are an important part of this work, and research funding from, sorry. Oh, it's not going forward. Which way is forward? And which way is back? It's all right. Got it. Research funding from Vision for Tomorrow, the Sharon Stewart Foundation, and Protokinetics Incorporated. Some time ago, we got interested in looking for novel therapeutics for a fairly rare ocular condition called aniridia. Fairly rare, an incidence of 1 in about 56,000. It's an interesting disease because there's the clear, obvious phenotype, which is lack of an iris, but it's also associated with all sorts of other abnormalities at the front of the eye and at the back of the eye, and even systemic associations that are only perhaps recently becoming associated with the condition, including things like obesity and diabetes. In the eye, the main abnormalities that you see are lack of iris tissue, corneal opacities, cataract, glaucoma, and foveal hyperplasia. These, especially the foveal hyperplasia and the aniridia, are congenital anomalies, so they're there at birth. Cataract and glaucoma come on later on. But foveal hyperplasia can be so severe that a lot of these patients have nystagmus and associated squints. Here are some patient pictures to show some of the ocular phenotype that you see in aniridia. Here you see little cataracts, anterior polar cataracts. The amount of iris tissue that's lost is very variable in humans. You can see here that very little tissue has been lost, but in this patient's non-identical twin, there's total absence of the iris. This is a patient that's had a cataract operation, and you can see the lens here, the intraocular lens, and you can see haziness of the cornea, showing that this patient is beginning to develop corneal disease, more severe corneal disease, and a normal control. Foveal hyperplasia I now use as synonymous with macular hyperplasia, and essentially you get loss of the foveal pit and loss of the specialization of the retina below the foveal pit. So a complicated disease, a genetic disease, autosomal dominant. We found that approximately 50% of patients with aniridia have a particular type of genetic abnormality, and that's called a nonsense mutation. So this is a mutation that leads to truncated protein being produced. In some patients with nonsense mutations, that truncated protein becomes degraded through nonsense-mediated decay. Sometimes these truncated proteins cause a gain-of-function defect. In aniridia, it's thought to be always due to nonsense-mediated decay and so a haploinsufficiency. So although it's a dominant disease, this is the rare example of a genetic dominant disease being haploinsufficient, lack of protein, rather than an overaccumulation of misfolded protein. There have been a number of nonsense suppression drugs developed, principally for non-ocular diseases. There's been lots of interest in using aminoglycosides as nonsense suppression genes. There have been some artificially generated aminoglycosides, synthetic aminoglycosides like NB30 that have been generated, and people have developed completely novel molecules in order to suppress nonsense mutations. And the reason for this is, as we've highlighted in aniridia, it accounts for a large percentage of aniridia, and nonsense mutations account for a large percentage of all genetic diseases. So I've put in the abstract 12%, which is at best an educated guess. We feel it's probably a larger percentage than that, but that's probably what you're talking about. So if you develop a nonsense suppression drug, the key thing about these drugs is that they won't work for just one disease. They'll work for many diseases, very many diseases. So they have very wide applicability. Atalurin, or as it used to be called, PTC124, is perhaps the most intensively investigated nonsense suppressor drug. That's not necessarily because of efficacy, but because it's associated with virtually no side effects. As you can imagine, long-term treatment, either systemic or even topical in the eye, of gentamicin is associated with lots of different complications. Atalurin is not associated with any significant complication when used in humans. So there are human trials already of atalurin, particularly in Duchenne's muscular dystrophy, and also to some extent in cystic fibrosis. So we thought that in aniridia, where we find a lot of nonsense mutations, we would try atalurin because of its efficacy, but mainly because of its safety profile. We were also lucky enough to find a very good mouse model of aniridia that has a very good nonsense mutation, the UGA mutation, which is the one that it's thought atalurin is particularly useful for. Now, the first thing to say about the mouse model of aniridia is it's much more severe than human aniridia. You get a very gross abnormality of the whole eye. And within a couple of months, this mouse has essentially a Thesical eye. This is the sort of thing that you see at P4, then further progression of the disease up to P14. So a gross defect, particularly thickening of the cornea, particularly very abnormal lens, and a lot of abnormalities in the retina. So we tried initially to treat these eyes with systemic atalurin, giving it orally, which is the way that the drug is given in humans with Duchenne's muscular dystrophy. And we saw something quite remarkable. These animals have been, this animal here is treated. This is an animal that's untreated. And if you just focus on, that's the diseased eye. This is the treated eye. What we've seen here is not an inhibition of disease progression. We see a reversal of the disease. A very diseased eye at P14 and a reversal of disease with systemic treatment. But that reversal of disease isn't perfect. And in particular, in the sclera, we see improvement, but still, this treated animal has not got a normal cornea. It's still thickened, and in particular, the corneal epithelium is still abnormal. The retina was dramatically improved, but even then, especially when we looked in the outer retina, there was still a lot of thickening of the retina, which suggested that the retina was to some extent immature. But the important thing is often function in these sort of studies. And in particular, in this phenotype, not only did we see a dramatic reversal in the appearance of the eye, but the function improved significantly as well. This is a normal ERG response, scotopic and photopic. In this untreated animal, you get no photopic or scotopic response at all. In the treated animal, we see not a perfect response, not all the way to what you would see in a wild type, but very close. So we see functional and structural benefits with the drug. We thought, though, that we could probably do better. And to be honest, in particular, we were focusing on the cornea aspect of the disease. And in that way, because of that, we went ahead and developed a topical form of atalurin, which we've given the name START therapy. When we give the drug topically in a simple solution, the animals don't like the drug. It's very irritating because the atalurin cannot be dissolved in solution. And so you get a very gritty suspension that the animals find very difficult to tolerate. We do see benefit with topical simple atalurin, but when we add these reagents to improve the comfort and essentially prolong the sticking time of the drug to the eye, we saw a very much better response. With topical atalurin, as you would expect, we see better corneal protection, better preservation of the cornea. Here you see the animal treated with topical solution. There was some interest from our reviewers that the effect that we were seeing with atalurin might be some off-target effect of the drug, that this might be something that is being caused by atalurin doing something bizarre. So we hypothesized that if atalurin was causing these benefits in the eye because of nonsense suppression, we should see an upregulation, more PAC6 in the eye. And aniridia is a disease that is due to mutations in PAC6 in humans in about 70 to 80% of cases. Our animal model was a PAC6 nonsense mutant. And with not only topical but systemic treatment, we do see more atalurin. We see atalurin getting to the retina with topical administration, and we see upregulation of PAC6 not only in the cornea, which is what you would expect with a topical treatment, but also in the retina as well. And if you look, almost to normal levels. The other thing that was remarkable about topical treatment was we were expecting to see some improvement in the cornea, but we got a lot of improvement in the retina as well, such that our ERG responses now are not only better than with systemic treatment of atalurin, but basically scotopic B wave and photopic B wave amplitudes are indistinguishable from wild-type animals. So the question that I always get asked is, when you treat these animals with aniridia, do they grow an iris back? Does it reverse the aniridia? Which seems like a very remarkable thing to do. These pictures aren't particularly good, and we'll have to repeat them, but essentially this is an untreated animal, and anybody would say that that is a very grossly abnormal eye. This is a treated animal. You'll notice that this animal's head is smaller than this animal's head. And we think that the systemic and topical treatment has some sort of effect on general well-being of the animal, which may be a function of PAC6 and its systemic functions. But it's probably more to do with a sort of holistic general health. Because the animals can see, they therefore feed better and therefore are healthier. But we certainly see growth of iris as well back into these eyes. So atalurin treatment, at least in this animal model, does seem to regrow your iris, which we found to be extraordinary. I've already covered the ERG responses. We also do optokinetic tracking. So this is a behavioral response in animals where they will track a moving object and essentially gives you a sort of surrogate for visual acuity. It's not exactly visual acuity, but it's almost visual acuity. And again, we see optokinetic tracking responses which are very near to normal. That was the stage that we were at a year ago. Since then, we've done a little bit of work looking at different dosages of atalurin, of start therapy, and essentially find that the 1% dose starting at P14 seems to be the optimal dose in the animal models. But importantly, the animals do respond differently to different dosages, which may well be very relevant when we move into clinical trials. In particular, if we give a reduced dose or an increased dose, we see this quite unusual thing in the lens, we get a thickened lens, a larger lens. If you look at the wild-type lens here, this is the mutant. With treatment, the lens is actually enlarged. And we also see abnormalities in the cornea with over-treatment. So this, when you know a little bit about the mechanisms by which PAC6 works, doesn't seem to be that unusual a thing to have identified. That PAC6 is known to be a gene and a protein that is very sensitive to dosage. This may not be true of all genes, but certainly it's true for PAC6. So issues of dosage and timing of dosage are very critical issues that are going to appear in our clinical trial. And in collaboration with PCC Therapeutics, we are going to be one of 2 sites that is going to start a phase 2 clinical trial this year. We've identified about 30 patients in British Columbia that suffer from aniridia, have genotyped them all, and have identified 7 patients that have nonsense mutations. So that's 7 out of 30, 5 of which have the best type of nonsense mutation for this particular drug. And finally, to move on to the idea that atalurin and nonsense suppression may be useful in other types of nonsense mutation in the eye. My speciality is retina, so I was interested in looking at atalurin for retinal disease. We've started to do a little bit of work with the RD12 mouse, see some benefit in the ERG response and some benefit in the outer nuclear layer thickness preservation over time. So we are definitely seeing some benefit with systemic atalurin in this RPE65 model. Not as much, we don't see as a remarkable as a result as we see with aniridia, but we think that that's probably because this is a recessive disease. Atalurin only increases the amount of protein by probably about 10%. So this may not be the ideal type of nonsense disease for atalurin. But we certainly do see some response, and we'll be looking at other genotypes over the next couple of years, both retina, more aniridia patients. We're particularly interested in choroideremia. Thank you very much.